You have heard a lot of semen analysis classes. Let me, just brief the semen analysis classes, whatever we have studied till now. Now, how does the semen analysis will help? It's very important to know. How does it help? Okay, it helps us to decide whether the infertility is due to the male factor. You should know this. And secondly, if if a male is infertile, it means, for example, if the semen analysis is abnormal, then it will tell us how severe is it. Okay, based on the semen analysis report, we can just imagine how severe the male infertility is. And thirdly, whether the male partner requires uroandrologist consultation. So whether we need him to send for an uroandrologist, okay, for consultation. So these things will help after doing the semen analysis. Now you know that the general causes of the semen, semen. Just to brief, what are the causes for the abnormal semen? Okay, one may be pre-testicular causes, which is 1 to 2%. Okay, there is hypothalamic pituitary disease. Okay, and it can be post-testicular causes, that is disorder of the sperm transportation. Okay, that is 10 to 20%, or it may be testicular, testes only. So testes only may be infected. So these are the main causes for the abnormal semen parameter. And there will be other than these causes, 60 to 80% the seminiferous tubule dysfunction. Okay, and it may be due to this genetic cause also, like Y chromosome deletion, all those things. As we know that this is commonly I always show this picture to you people, and see, this is commonly like that this is a testis, this is epididymis, vas difference. Okay, this is seminal vesicle joined together to form ejaculatory duct, and this is a urethra. Okay, and you can see here bulbourethral gland also opening to the urethra. Okay, penile part of the urethra. So why this is very important? Because there can be obstruction in these areas. I'm just showing you there can be obstruction at the region of the ejaculatory duct. There can be obstruction at the level of vas difference, and in this area also there can be obstruction. These are the areas where there will be obstruction. If there is any obstruction, finally the fructose test, as I told you, fructose test is not an suitable test to tell whether it is obstructive or non-obstructive azoospermia. If it is obstructed only in the ejaculatory duct, you can tell, okay, obstructive, whereas it can get obstructed here or here. So the main purpose of knowing the anatomy is to know the about the obstruction of this semen. Then coming out briefly about the seminiferous tubule. So that seminiferous tubule is present inside the testis. So that the seminiferous tubule will be present inside the testis. Okay, and it mainly produces the spermatozoa. Okay, and it provides the support to the cells. Like I can just show you here. You can see here. Sorry, you can see here. These are seminiferous tubule. Sections of the seminiferous tubule. They have taken section of this. So you can see here these are Sertoli cells. Okay, and in between the Sertoli cells, you can see the developing spermatogonial cells. And in between the seminiferous tubule sections, you can see the Leydig cells here. See, these are the Leydig cells. So this is brief about where the semen is produced. The sperms are produced. Now coming on to this, how to collect this when the sperm is not retrieved by the normal ejaculate, how we collect the sperm. So we collect the sperm with the help of TISA. That full form of TISA is testicular sperm aspiration. We can collect through this TSA, this testicular sperm extraction. Okay, that means what? A small piece of the testis, then it is removed. It is and this is done under the microscope. a small piece is removed, then we dissect it under the stereoscope microscope and we try to search the sperm. And the third procedure is like PESA, percutaneous epididymal sperm aspiration, PESA, PESA. That we directly aspirate the sperm from the head of the seminiferous tubule. And fourthly, it is MESA. So this is done under the microscope. Again, microsurgical epididymal sperm. Uh, uh, Microsurgical epididymal sperm aspiration. Okay. And now coming on to the semen analysis. So let me talk briefly the critical points of the semen analysis, not as a whole. That usually we evaluate the volume of the semen, sperm count of the semen, sperm movement of the semen, and sperm movement, how the sperm is moving, sperm shape of the sperm, and white blood cells. So these are the 5 parameters we see in the semen. Okay, why we see the volume means the amount of semen. Why we see that? Okay, so this volume will tell whether the patient is producing enough amount of the semen sample. Why we do sperm count? It tells how many sperms are there. We do sperm movement, then the sperm motility tells that how many sperms are moving. Okay, we do this shape. We see the shape of the sperm. Like it tells how the sperm will look like. Okay, and finally the white blood cell. It tells whether the semen sample is infected or not. So why we do these things? So these things will answer these questions. So mainly we do quantity and quality assessment. Now, coming out the semen composition, so these are the cellular component of the semen sample, which I have already discussed many times. And these are the seminal plasma. Okay, in the plasma, what are the components? Now, I think these pictures I have already shown you. So 60% of the semen volume is contributed by the seminal vesicle. Okay, then 20% is by the prostate gland. You should know that the prostate gland has proteolytic enzyme which will dilute the semen sample. Okay, and it has testes which contributes less than 5% of the semen volume. Okay, then 10 to 15% of the semen volume is contributed by the bulbourethral gland and the glands along with the urethra, and also this epididymis as well as vas deferens. Okay, now coming on to the semen analysis. So this semen analysis is done under 3 parameters. Then under 3 headings, I can say: pre-analytical, analytical, and post-analytical analysis. Now coming on to this pre-analytic analysis. So these are the pre-analytic analysis. Like we see whether there is an erection problem, whether there is a varicose vein, whether there is a genetic problem, or whether the patient has undergone any radiation therapy. Okay, or whether the patient has a history of mumps, or whether he has retrograde ejaculation, or because of this diabetes, or whether his hormonal levels are compromised. Everything we will check. These are called as pre-analytical part. Okay. Now the main thing you should tell the patient to maintain the abstinence. Okay. The moment the patient comes and meets you for the semen analysis, this is the main thing: 2 to 7 days abstinence. Okay. So longer the abstinence, what happens? You should know what if it is the abstinence is longer, the sperm vitality, the sperm survival decreases. Means you will get a lot of dead sperms, and there will be the progressive motility also decreases. You may not see the more progressive motile sperms. You may see immotile sperms, non-progressive motile sperms. Okay, and there when there is a long duration of more than 7 days, even DFI test, it will be positive. There will be DNA fragmentation will be more, and if there is less abstinence, okay, less abstinence, your only this is compromised. Sperm concentration will be less, but you can see good motile sperms, and you may sometimes give that if the sperm volume is less, you may give hypospermia. Okay, if there is 1 day gap, you may give it's a wrong report actually. So for that reason, so in less abstinence, we can use this sample for the ICSI procedure, all those things. No, for IUI, for less abstinence. For analysis, we should maintain 2 to 7 days, not less than 2. At least 2 days abstinence is needed. So this we have already done in the webinar also. Semen collection. The semen collection, the patient needs to have a full name, his wife name should be there, medical record number should be there, because names will be similar, and date of semen collection should be there, and time of specimen collection also needs to be there. So everything should need to be written in the bottle in the front as well as on the cap. Method of collection, masturbation, and you can use a silicone condom or coitus interrupts. So patient, you have to instruct, patient is instructed to masturbation. He should be instructed not to use any lubricant. Okay, and he has to ejaculate in a wide mouth container so that the spillage is avoided. And the first part of the ejaculation, you should always tell the patient, first part of the ejaculation should be inside the container. It's very important, because 70% of the sperms are present in the first part of the ejaculation. Okay. Now coming on the precaution, what are the precautionary measures we'll collect the semen sample? In a special situations, I can tell you, when the patient is unable to collect the semen sample, okay, for analysis only, okay, you can tell the patient to collect at home, or he can use the partner's help, or he can use visual aids or psychotherapy, or any other medications. And coitus is also allowed. This special, they can use this special condom, and assisted ejaculation, electro ejaculation, used in a paralyzed patients, we can do that. And it is very, very important, if the patient is going for a home, okay, if he is collecting from home for the IUI or IVF procedure, we need to take consent. Okay. And after once the patient is ready to collect the sample, we usually send them to collection room. Okay. So then we go for analytical part. So in this we see macroscopic and microscopic analysis. Macroscopic, as you know, volume, viscosity, and pH we check. Microscopic we check concentration and motility. So macroscopic analysis we see for liquefaction. Okay, normal liquefaction is 15 to 30 minutes according to the current WHO manual. Okay, above 30 minutes you should start recording it. Okay, and if it is more than 16 minutes, okay, you may get decreased motile sperms. The sperm may get trapped, okay, in the clumps, and in clumps it can get blocked. Okay, then it may be if it is taking more time for liquefaction, then there may be, we can predict that there may be a prostatic infection. Okay, because proteolytic enzyme is not released. If the proteolytic enzyme is not released, it will not liquefy. So there may be some prostate infection. We can assume that. Okay, what about volume? So reduced volume, I told you, if the patient is giving less than 1.4 ml, okay, then it may be due to retrograde ejaculation, or it may be due to the duct obstruction, or it may be due to congenital or acquired or agenesis, Semen vesicle disease or hypogonadism. So these are all the causes. And low volume cannot neutralize the vaginal acidity. So low volume, the sperm will never swim to the uterus. Okay, this is the cause of infertility. And if there is an increased volume, so it can be due to the age. Young people will do increased volume. Okay, sometimes when there is genetic factor. Okay, if very high, if it's hyper, he can also give a lot of volume semen sample. And if he drinks more water, before ejaculate, he can give more amount of semen sample. And if he's abstaining for more than 10 days, the volume will be more. Yeah. And and the person who is having sexual intercourse with his partner for very, very less frequently. Okay, and what happens when there is more? Okay, it can dilute the sperms, okay, and or it can be due to this active infection. And odor, that odor is like it is we can say sorry, or not order color. It is whitish gray in color. Sometimes it can be yellow, pink, reddish brown. If this is the pink reddish brown, it may be due to it is called as hematozoospermia, or hematozoospermia. So these are the causes. Blood thinning. You may be having blood thinning medications, or it may be having long periods of abstinence, or in long period of abstinence due to that gush, that the capillaries can rupture and send the blood in the semen sample, okay, or due to any infection like UTI infection also you can see blood in the semen sample, or in any sexually transmitted infection also you can see the blood in the semen sample, okay. And even in the prostatitis and prostatic cancer also you can see blood in the semen sample. Order, no, normal order is like ammonia, bleach, or chlorine. It depends on the diet and hygiene. Usually, when you get bad smell, okay, it has to disappear. Like after some time, no, you should not get it. If it is sustained bad smell, then there is an infection, or like I just discussed with you, like see here, if for short duration it is okay. So short duration may be due to these reasons, okay. And if it is long duration, it may be due to this trichomoniasis or gonorrhea or prostatitis. So this may be the reason if the smell persists for the long time. And pH, that pH strips are easily available, okay. And it determines the acidic or basic pH. The normal pH is more than 7.2 according to WHO manual, okay. The pH is determined by pH meter, as I told you. Increased pH increases with the time. If you keep the semen sample without analyzing it for the long time, means more than 1 hour, the pH can go for alkaline. In pH increases, it goes for basic pH, alkaline pH, okay. And this will decrease what buffering capacity of the sperm, okay. And decreased pH may be due to this prostatitis or low semen volume. And viscosity, coming out of viscosity is always smooth and watery, and should come out as a discrete drop by drop. It has to follow. Then it is a good sign of viscosity. If it is more than 2 centimeter like thread, you can just grade it 1, 2, 4, okay. And if it is more high viscosity, it can slow down the sperm movements. Okay. Now coming on to the microscopic analysis, mainly we see the concentration, sperm motility, and sperm morphology. Also some the cellular elements. So this is a macular chamber. We do this microscopic analysis. So I have just discussed with you these things. Okay, I'll just skip this slide. So this is a macroscopic analysis. Then we go for motility. So motility, the total motility is 42%. Progressivity is 30%. Any one decreases, it is called as asthenozoospermia. Okay. And see, this is a normal motility. This is a normal motility, and this is an abnormal motility. So these are the terminologies which is used for motility: asthenozoospermia, oligoasthenozoospermia, necrozoospermia. Necrozoospermia means all the sperm are immotile. Not all the sperms are immotile. If the sperms are more than 54% of the sperms are immotile, okay, then it is called as necrozoospermia. Okay. Hope you have understood. Now coming on to this sperm motility. Sperm motility, these are the factors affect the sperm motility. Age, health condition, long sexual abstinence, excessive heat and toxins, method of collection, or inadequate handling in the lab. So these are all factors which will affect the motility. Normal motility is more than 30%, and if less, so these may be the causes for the less motility. Okay. And coming on to this sperm, now in current edition, in old edition it was progressive, non-progressive, immotile sperms. and total motility. But now you have to assess fast progressive, slow progressive motile sperms, non-progressive motile sperms, and immotile sperms. So this is so under this criteria you have to assess. So this is grade A, grade B, grade C, grade D. So grade A, like a rapid progressive, you should move this in this line. You should move. You see, this is a grade A. Okay. Now what about grade B? Grade B will move actively moving sperm. Okay, in a straight line in the large circle. Okay, but speed is less. Grade C sperms. So this is grade C sperms. It will not move in a straight line. This is grade C sperms. Okay, and the grade D sperms. No, these are non-active. No, only that only means it won't move. Only tail will be beating. It is a grade D. So it's always important according to the WHO manual. No sixth edition. You have to do grade A, grade B, grade C, and grade D. Okay. Coming to the sperm morphology, you know that the length of the sperm is 4 to 5 micron. Width of the sperm is 2.5 to 3.5 micron. Okay. And the acrosomal area, okay, it should be 40 to 70% of the head of the total head of the sperm. And the mid piece width and length, okay, width should be less than 1 micron and length should be less than means 76 to 7 micron. And tail should be like 45 micron. These are all things you can't measure. These are all like with experience you can just see the tail should not be very short. When you study normal morphology properly, you can just assess. So these are all head defects. Okay, in a head defect, this is very important head defect. Rest everything is or like you can identify. People will not identify this. No acrosomal space, just called as globosus for me. It's very important to know that. And these are the vacuolated head. Okay, so these are the commonly seen from vacuolated head. Okay. If the vacuoles, one or two vacuoles, it is normal. If it is more than two vacuoles in the acrosomal space, it is abnormal. And if the vacuoles are in the nuclear region, it is abnormal space. Okay. So these are the neck defects like bent neck, asymmetric neck, thick insert means thick neck and thin neck. Okay. Now coming on the tail defects. The tail defects can be the short tail, bent tail, and the point tail. These are the tail defects. And these are the micro. This is cytoplasmic or droplet. Okay, excess cytoplasm. Okay, and more than 1/3 of that. If it is usually, we can select this form for ICSI, but if it is more than the head, okay, it's better to avoid it. Now staining method. So in the staining method, usually, very, very important thing is that we take stain A after fixation, we take stain A and stain B. And stain A we keep in 1 minute, that is eosin, and again in the basilic stain, that is thiazine, we keep, that is stain B, we keep 1 minute. So this will decide actually 1 minute you have to keep. Okay, it depends on the protocol which method you use, and here we use a diff fix stain. So this is a normal slide which you can see after the stain. So this is a normal sperm. So normal sperm will look like this. Okay, and this is an abnormal sperm, and this is also an abnormal sperm. This is a normal sperm, abnormal sperm. These all are abnormal sperms. Okay, so these are also, see, this is a normal sperm. And then all are almost all are abnormal sperm. See, this is also abnormal sperm. Okay, and this is also an abnormal sperm, and this is normal. See, normal sperm will look like this. This is normal sperms. So these are the terminologies we usually use to report the sperm. Oligospermia, sperm concentration less than 16 million, asthenospermia, sperm concentration less than 42 or less than 30%, or any one. Teratospermia less than 4%. Oat, oligo, this when we combine these three, oligo, teratospermia, azoospermia means that polyspermia, high concentration, more than 200. Hypospermia means less volume. Hyperspermia means more volume. Aspermia means no volume. There is no semen sample at all. Pyospermia or leucospermia or leukocytospermia. It is like if you have more than 1%. Okay, and hematospermia, I told you, globospermia, I told you, necrospermia, more amount of dead sperms. Okay, and cryptospermia, no sperms initially seen, but after centrifugation you are able to appreciate this one. Means hidden sperms are called as cryptospermia. So these are the commonly used terminology. Okay, and after analysis, this is post-analytical. If the sperm parameter is very severe, based on that we decide IUI, IVF, or ICSI. Okay, so limitations of the sperm semen analysis. The errors are more common if you don't do it properly. Okay, particularly in the low concentration. So sixth addition mainly concentrates on the low concentration semen sample. Okay, now secondly the counting errors. Counting errors. So there will be lab variation. Okay, one lab can give 200, another lab can give 50. So this is a huge variation. This is wrong counting. Okay, and it's very important to take the patient history. Okay, whether he has lost, whether he has maintained proper abstinence. Okay, all those things are very important. Okay. Now, thirdly, for morphology, even we count the dead sperms. So this is one of the limitation. And if more than 10 pus cells are present, no proper guidelines for semen culture. These are all drawbacks of limitations of semen analysis, and differentiation between the pus cells and gonian cells. Still, the protocol is not proper. Okay. So this is about the andrology lab setup. Okay, and this is a conclusion. You should know that the spermatogenesis happens in the seminiferous tubule. Sperm maturation happens in the epididymis. Propel means propel sperm to ejaculatory duct. It is done by the ductus deferens, means pushing the sperm to ejaculatory duct. And finally, coming on to this, prostate gland provides enzyme and proteins for the coagulation and liquefaction. Bulbourethran gland, okay, it neutralizes the mucus, because the first portion before the semen comes out, some watery thing will come. So that's all, and this is my reference. Thank you. Any doubts?
Sir, one doubt.
Yes.
That necrosis spermia is dead sperms, no sir? So the vitality will be, if it's more than 54%,
okay.
then how can they be dead sperms?
Necrosis spermia means word. Okay, word meaning is dead. Okay, vitality, vitality. Now, what is a normal vitality? What is a normal vitality?
54%.
54% is a normal vitality. Okay. Now, if the vitality is less, okay, vitality is less, then it is called as necrosis spermia. If vitality is more, but still all the sperms are immotile. Vitality means what? Live sperms are more, but still all the sperms are immotile. Then it is called as absolute asthenosis spermia. Hope you have understood.
So if
Yes,
the
now I understood.
all the
Not
sperms
all
are
testes will never produce all dead sperms. Okay, sperm may be immotile. Sperm may be immotile.
So to differentiate between dead sperms and immotile sperms, vitality testing has to be done.
Okay, see what I mean to say, if the percentage of dead sperms are more, then it is called as necrosis sperm. Yeah. It is necro means not all sperms are not dead, all sperms are immotile. I can tell you this.
So less than 54% vitality is necrosospermia. More than 54% vitality is absolute asthenospermia.
Absolute. It is not necrosospermia. That means what? It's absolute asthenospermia. Nothing is moving. Okay. And asthenospermia, we give it for less than 42% or less than 30%. Okay. That is only asthenospermia we give. Absolute is for.
Got it.
You got it, no? Okay.
Okay, sir. Understood. Thank you.
Thank you.
Thank you, sir.
Thank you.